Uh, okay, okay. Today's lecture is our testicular tumors. So, in testicular tumor, it represents 1% of all the cancers in a man. In definition, we can define it like this: the cancer that forms in tissues of one or both of the testes. Testicular tumor is very much common in young or middle-aged men. Most testicular cancers begin in germ cells. These are the cells that make sperms in male. And these germ cells, they make ovaries in case of females and are called testicular germ cells tumors. The clinical feature presentation due to primary tumors is a painless testicular lump, sensation of heaviness, the size is more than 2 to 3 times of the normal size. Rarely dragging pain is complained and sudden pain and enlargement due to the hemorrhage and torsions. History of trauma have got no significant effect on developing this tumor. Due to metastasis, there is abdominal lumbar pain, mass in epigastrium, dyspnea, hemoptysis, and chest pain with the lung metastasis. Jaundice with liver metastasis and hydronephrosis for para-aortic lymph and nodes enlargement. Pedal edema by inferior vena cava obstruction, and these are Droser signs. Predisposing factors are cryptocortisms, positive family history, positive personal history, intratuberous germ cell neoplasia, trauma, hormonal factors, and exposure to environmental estrogen contamination. And cryptocortisms, most important risk factors, 6 times higher risk. Risk reduces to 2 to 3 times if the surgery is done for these cryptocortisms. 1 in 5 will have tumors in the normally descended testes. Positive family history, man with first degree relatives with testicular cancers, median age being less than 2 to 3 years, affected brothers and affected father 2 to 4 times. Positive personal history, 12-fold increased risk of developing germ cell tumors in the contralateral testis, that is the second testis. Intratuberous germ cell neoplasia consists of undifferentiated germ cells having appearance of the seminoma located basically in seminiferous tubules. No spermatogenesis and 5 to 9% affected contralateral testis increased to 36% trophy cryptocosis. Other is a trauma is another predisposing factor. No link proved yet between the trauma and the testicular tumor. Hormonal factors are there throughout, thought to be the contributing factors, and the peak incidence after puberty. Tumors are more common in dizygote twins than the monozygous one. That is the exposure to environmental estrogen and contaminations. The symptoms of testicular cancer are painless lump in the testicles, swelling of the testicle larger than the usual one, pain in dull ache in the testes, build up fluid in the scrotum, pain in the back of the abdomen, gynecomastia, enlarged lymph nodes in the neck. Besides it, there is trouble breathing, hemoptysis, chest pain, difficulty in swelling in the chest, pleural effusion, weight loss, infertility, and headache. Classified according to the predominant one. Germ cell tumors may be classified into seminoma, embryonal cell carcinoma, choriocarcinoma, yolk cell tumor, and teratoma. These are the germ cell tumors. Non-germ cell tumors are interstitial cell tumors like Leydig cell tumors, Sertoli cell tumors, gonadoblastomas, granulosa cell tumors. Miscellaneous testicular neoplasms are epidermoid cyst and adenocarcinoma of the testes. Secondary tumors are lymphomas, leukemia, infiltration, and metastasis. The tumor of testicular adnexia are the adenoid tumors, cystoma, and mesothelioma. The other classification is like this: germ cell tumors and non-germ cell tumors, GCT and GCT. In germ cell tumor, we have seminomas, non-seminomas. And the non-germ cell tumors, we have sex chromosomal tumors and others. The germ cell tumors, there are two main types of germ cell tumors are there, the seminomas and the non-seminomas. The germ cell tumors can be made up of mixture of seminomas and non-seminomas. These tumors are called mixed germ cell tumors. They are treated like non-seminomas. These tumors, they are called extragonal tumors, cell tumors, those tumors which starts outside the testis. So the extragonal tumors can start anywhere in the body, and they usually start in the area between the lungs, abdomen, lower spine, and pineal glands in the brain. Seminoma, they localize to testes only. Seminomas grow slower than the non-seminomas. Seminomas most often develops in men in their 40s. It is most common in malignant tumors in the testes. It has a better prognosis other than the germ cell tumors. Undescended intestines tend to harbor seminomas. It is very rare in children. Patients will present with the painless testicular tumor, 30% metastasis at presentation. Seminomas are very much sensitive to radiations. The seminomas, they are typical bulky masses, homogeneous gray-white lobulated cut surfaces. Usually no necrosis or hemorrhage are there. Is a microscopy. Other some testicles, cancer tumors are there. They are the microscopic features. In the seminomas, serum alpha protein is normal, but the HCG is elevated. The clinical feature, peak incidence is between 34 to 45 years of age. Gynecomastia and infertilities are very rare, presenting symptoms. A fraction of cases may be present with symptoms of metastasis. Most patients present with a typical painless testicular enlargement also. Now the spermatocytic tumors, called previously they were called as spermatocytic seminomas and classified as germ cell tumors. Signs and symptoms are a very rare tumors making up only about 2 to 3, 1 or 2% of all testicular germ cell tumors. Men presenting with this tumor generally 50 to 60 years of age. Occurrence is rare in men under 30 years of age. It looks like it is hemorrhagic and cystic changes can be seen here. Diagnosis, spermatocytic tumors are diagnosed based on tissue orchiotomy and suspicious of cancer for medial imaging. The macroscopic appearance of tumor is of multinodular gray-white to tan-colored mass with gelatinous hemorrhagic and necrotic area. The tumor may extend beyond the testis. Non-segmental tumors, their type of cancer, it begins in a cell that forms the sperms or eggs. Extension to the epidermidis, spermatic cord, and scrotal sac. Tumors that have 100% seminoma cells are considered seminomas. Non-seminomas contain different types of cells. Blood test is one of the ways of determining the types of testicular tumors. Non-seminoma is the most common type of testicular cancer, tends to grow more quickly than the seminoma. Non-seminoma tumors are often made up of more than one type of cell and are identified according to these different cell types. There are four main types of non-seminomas: embryonic carcinomas, yolk cell carcinomas, and choriocarcinoma and teratoma. In the embryonic carcinoma type of non-seminomas tends to go quickly and spread outside the testis. The yolk cell carcinoma is rare in adults and the most common form of testicular cancer in children and in babies. And the choriocarcinoma is a rare and aggressive type of testicular carcinoma. It can spread quickly to distant organs, including the lungs, bones, and brains. Teratoma has area that looks like each of the three layers of developing evidence. These layers are endoderms, mesoderm, and ectoderms. The pure teratomas are rare. This type of cancer is often part of mixed cell tumors. Yolk cell tumors. In the yolk cell tumor, microscopically, we find some bodies which are known as Schiller dual bodies. They are very diagnostic feature of the microscopic feature of the yolk cell tumors. In the teratoma, a pure form of teratoma, pure is a subtype of non-spermatic, are fairly common in infants and children. In adults, the pure teratoma are rare, considered 2% of 3% germ cell tumors. However, frequency of teratoma mixed with the other germ cell tumors was 45%. Teratoma divided into two main categories, mature and immature. The mature type of teratoma is usually non-cancerous and reoccurrence can take place. Most ovarian teratomas are mature ones. The immature type of teratoma is more likely to grow into cancer. These are typically larger, 14 to 25 centimeter in area, more mature cystic teratoma. They may be solid, prominent solid component with cystic element. Clinical features of post-pubertal teratoma seen in younger children than 4 years with a mean age of 20 months. And most post-pubertal pubertal cases are young adult presenting with a testicular swelling or sometimes with symptoms associated with metastasis. Mode of spread of teratomas are lymphatic spreads, metagenous spreads. These teratomas they derive from embryonic cells, usually occurs in the brain, elsewhere in the skull, the nose, in the tongue, under the tongue, and in the neck, cervical teratoma, mediastinum, retroperitoneum, and attached to the coccyx regions. Grossly, they are usually large, ranging from 5 centimeter to 10 centimeter diameter. Because they are composed of various tissues, gross appearance may be solid, sometimes cartilaginous and cystic areas. Hemorrhages and necrosis usually indicate a mixture with the embryonal carcinoma and choriocarcinoma or both. Pure testicular teratoma in adult is relatively rare malignant tumor with the ability to invade the end metastasis. These are the few pictures of the testicular carcinoma or tumors. Sex cord tumors, sex cord stromal tumors are also called sex cord gonadal stromal tumors. Start in cells of stroma, which is fluid tissues in the testicle that makes the hormones. Two main types of stromal are there: Leydig cell tumors and Sertoli cell tumors. Leydig cell tumors, clinically, the Leydig cell tumor comprises 3 to 5% testicular neoplasms, occur in both adult, 80%, and in children. Children present with endocrinological symptoms and adults present with testicular mass and some 10%, 30% have gynecomastia. In women, due to excess testosterone secreted by the tumor, one-third of female presented with a history of progressive masculinization. It is preceded by the anevolutions, amenorrhea, and defeminizations. Additional signs include acne and hirsutism, voice deepening, platelomegaly, and increase in the musculature. Serum testosterone level is high. In men, testicular swelling is common. It is secreting androgens. Tumor is usually asymptomatic, and the tumor secreting estrogen, then it causes feminization in adult boys. In adults, it can cause gynecomastia, erectile dysfunction, infertility, feminine hair distribution, and loss of libido. Radic cell tumors, they produce androgen, estrogen, and corticosteroid, any age, usually 20 to 60 years of age. Testicular swelling is causing gynecomastia, morphoricum and nodules less than 5 centimeters, golden brown cutage, and histological Leydig cells with Ranke crystals are present there in this Leydig cell tumors. We do ultrasound when palpable scrotal lump is present. Histology, Ranke crystals are clinically found in these tumors. Leydig cell tumors, macroscopically. They are radic crystals. They are rod-like cytoplasmic inclusion bodies, which can be found in Leydig cells of the testis. Sertoli cell tumor, sex cord tumors of Sertoli cells. They are very rare and usually occurs with the age of 35 and 50 years of age. Sertoli tumors clinically account for less than 1% testicular tumor. Occur both in children, patient with present with testicular mass and estrogen production by tumor can result in gynecomastia and impotency. Sertoli tumors well described and often lobulated cysts are common. Sertoli cells are typically arranged in tubule or infiltrated with seminiferous tubules. Macroscopically, well circumscribed, solid, pale yellow or white or grey mass. Large size and necrosis are worrisome features of malignancies. Granulosa cell tumors, much less common than the adult female. Ovaries, average age is 42 years. Gonadoblastoma, they are composed of a mixture of seminoma cells and Sertoli cells. Occurs in dystenic gonads in patients with intersex syndrome. Macroscopic solid yellow to tan tumors in male testes are cryptorchids. Lymphoma is a group of blood cancers that develops in the lymphatic system. The two main types are the Hodgkin lymphomas and the non-Hodgkin lymphomas. The lymphomas are the cancer of the lymphatic system, part of the body germ cells fighting network. Lymphomas are cancer that begins with the malignant transformation of the lymphocytes in the lymphatic system. The lymphatic system includes lymph nodes, glands, spleen, thymus, glands, and bone marrow. Lymphomas can affect all those areas as well as other organs throughout the bodies. Lymphomas are categorized into two broad groups, Hodgkin's and non-Hodgkin's lymphomas. Non-Hodgkin's are both types occurs in either children or adults. Most lymphomas arises from the two main types of white cells called lymphocytes, B cells or T lymphoid T cells. Lymphoma is cancer that begins in infection-fighting cells of the immune system called lymphocytes. These cells are in the lymph node, spleen, thymus, bone marrow, and other parts of the body. In lymphomas, lymphocytes change and grow out of control. Non-Hodgkin begins when the type of white cells called T cells, B cells become abnormal. The cell divides again and again, makes more and more abnormal cells. These abnormal cells can spread to almost any other part of the body. There is an increased risk if they develop a weakened immune system, which may have certain types of infections. Hodgkin lymphomas differ from the other form of lymphomas in prognosis and several pathologic characteristics. Hodgkin lymphoma is marked by the presence of a type of cells called Reed-Sternberg cells. The difference between these two categories, lymphatic cancer, is the type of lymphocytes that is affected. Hodgkin lymphoma is marked by the presence of Reed-Sternberg cells. In non-Hodgkin lymphoma, these cells are not present. These are Reed-Sternberg cells. Looks like owl body, owl eyes, lymphomas. Sign and symptoms. painless swelling of lymph nodes in the neck, armpit, groin, persistent fatigue, fever, night sweat, shortness of breath, unexplained weight loss, itchy skin. Intratubular germ cells. Intratubular germ cells replaces a precursor lesion for the invasive germ cell tumors. Identified almost all testes with invasive germ cell tumors except testes with the spermatocytic seminomas. Involvement is patchy and 40% cases are bilateral. Thank you very much.